Thank you guys for coming out tonight. We greatly appreciate it. We're going to talk about some kind of new exciting procedure that Dr. Linehan's been doing, great outcomes. We just want to share it with you. I know everybody kind of gets in this tunnel vision of what they're doing in their own practices and their own treatments. So I love doing these because we get out, we get to share about what everybody's doing, and yeah. So I'm going to turn it over to Katie. Katie does our marketing. She's going to give you a little history of the company, and then we'll talk more about patients, who this is right for, and how maybe we can help in your practice. So.
Awesome, thank you so much. And Ashley manages our Ohio and expanding territory, so I really appreciate everyone coming out. You guys for inviting me down. Don't take my car because it's a Michigan plate. I didn't have time to rent a car from here. So I kept thinking about on my way here. Spinal Simplicity, I'll go through the history, but our product is called the Minuteman. And a little history about it, because if you look at our inserter and you hear Minuteman, our CEO is a very, very patriotic. So it is actually based on, does anyone know the history of the word Minuteman? It is, you do. Tell me. Because no one knows it. No one knows it. Do you really know?
I mean, a little, but just,
like, so back in,
yeah.
Back in, like,
You should know.
yes, you will. Okay, so pre-Civil War, it was like self-appointed people that would be called at a minute's notice to defend the country. And so that they weren't part of the military, they were just self-appointed that way. And so our Todd Mosley is a very big patriotic person. He's like, that's my staff. Like, wherever you call, wherever you are, we will be there at a moment's notice. So our device is called Minuteman. So I had to ask him that question one time. I was like, okay, I'm getting this a lot. Like, I want to know like where it came from. So we're going to go over kind of the company history before I turn it over, and he'll go through all of the kind of stuff that can pertain to your practice, the procedure, and how we can kind of partner together. So it was founded by Dr. Hess and Todd Mosley. And as much as Todd was here, he would say it's the 13-year overnight success. So it seemed from the outside that this like came out of nowhere, but we have actually been around for 13 years. And they had a history in spine. So this was placed just in orthopedic spine and neurosurgery long before it was in the hands of interventional spine and interventional pain. So it has been implanted for a long time. We actually, and I'll go over that there of where we started, and we have patients with 10-year outcomes. So our goal is to be the global leader in innovation, and we strive to do that every single day. So in 2011, we brought the implant to Europe. In 2014, we submitted for FDA clearance. 2017, we added HA coating, which is hydroxyapatite, to our implant. And that's used a lot in orthopedics to help promote a fusion. Very little use in this space. So 2019, we launched in the US in the spine market. In 2020 for interventional pain. In 2020, Dr. Beal and Dr. Jasper were the first ones to put it in here. We got the clearance for lumbar spinal stenosis in December of 2021, and we just launched our G5 generation in March. So we have been in Europe, we have patients that have been implanted for 10 years. So this is, while it might be new to all you guys and learning about today, it is not new, and it's not new inside patients'
December
bodies.
was very exciting with the stenosis.
Yeah, so it was to our knowledge, and this is what I was told, it was the first of its kind to be a fusion device to get a stenosis indication. So it's usually just spacers, not fusion devices. So with that, I'm going to turn it over to the man of the hour that you actually came to see, and not me. So
Thank you, Kate.
here we go.
Thanks, everyone. Yeah, I appreciate you guys coming out. You know, something that Katie had said, I think is important to realize, that this was initially presented to orthopedic spine and neurosurgeons for spine procedures. And a lot of the things that I do that you guys have referred patients for, compression fractures and kyphoplasty and spinal cord stimulators for, refractory back pain and spinal infusion pumps and all these more advanced interventional pain techniques often were started in the orthopedic and the neurosurgical spine realm. But because they require very succinct and very specific needle placement, there was a lot of frustration for specialists that really weren't trained in needle placement. And I remember doing a procedure years ago, I think it was a percutaneous discectomy or something. And they said, yeah, we tried to, or an endoscopic discectomy, which I still do endoscopic spine surgery. And they said, we went to the orthopedic and the neurosurgical spine guys, but they were so trained in the idea of opening up with the scalpel, when it came to being very precise in their needle placement, they'd get frustrated, throw the instruments down and say, hand me a scalpel. And they're like, we can't make our business grow if everybody's that we're trying to teach is frustrated. So a lot of the things that we do now kind of bridge this gap between the traditional pain management, we start with the physical therapy and the chiropractic care and, anti-inflammatories and muscle relaxants and time and all the other basic stuff that we try to temporize and treat some of these chronic pain problems with. And when they failed, then they went on to injections, which was generally the realm of, your pain guys. But if they failed that, then it was either throw a bunch of opiates at them, which we know where that got us, or they're off to a surgeon. And, a lot of these surgeries were pretty aggressive, multi-level laminectomies with pedicle screws, infusions, and we all saw the results of that. 5-year success rate is dismal when you're looking at this. So having these minimally invasive techniques that are available now, where patients can do these things as an outpatient. I do these things with MAC anesthesia in most cases. They're not put under general anesthesia. And we look at the indications for these treatments. Spinal stenosis, number one for this, but degenerative disc disease and spondylolisthesis, where there's some minor movement. This wouldn't be something I would do for a grade 2 spondyloma, but a grade 1, perfectly reasonable. Well, these kind of things are more common in our elderly patients who, just as a result of being elderly, tend to have a lot more medical conditions that would prevent more traditional surgery from really being entertained, and they're lost to treatment options. What are you going to offer somebody that has, cardiac disease and severe diabetes and emphysema and all the rest of the things that come with the normal aging process, and they develop these pain problems that are debilitating, and the next thing you know, you don't have any options. Now we do. And I gotta say, I've been very impressed with these interspinous spacers. And I've been doing this for a couple of years now. And the Minuteman is a newer procedure in my tool bag and has some real advantages over the previous interspacer placement that we'll get into more. And I'd like you to look at these models that are on your tables and stuff like that, because I think I can explain why there's some major advantages with this approach. But as you can see, there's a huge increase in the number of patients that are developing spinal stenosis. We all see it. What do you think of when you hear spinal stenosis? What's the first thing you think about, Sarah?
I just think chronic back pain patients that are just...
Can be back pain. You can also get that, the radicular symptoms, but I always think of the shopping cart syndrome. These little old ladies at the grocery store, and they're leaning on that cart, and you can tell they're struggling. It hurts. And the pathognomic features for spinal stenosis are inability to stand and walk any length of time without increasing pain, be it back, leg, combination of both. And if they sit down or lean forward on a cart, it just gets amazingly better. And it's so common, we don't even ask patients this commonly. I don't know how often you ask it in your offices, but it's a very common problem. So now we got an option that if they fail the conservative things, because you just don't jump to this kind of stuff, you have to start with the conservative things. But now you got an option, as opposed to sending grandma to a neurosurgeon who's gonna wanna do a 3-level laminectomy with pedicle screws that she's probably not gonna tolerate in the first place, and maybe even get medical clearance to do.
Or, you know, a lot of these people are so old and they have so many chronic medical problems that you don't want to send them to a surgeon.
Exactly.
It's kind of like, well, you have to live with it.
Or
And-
they won't pass anesthesia. You send
Yeah.
them to a surgeon, they're like, we're gonna send you into spine purgatory. Like, we can't do anything to you, and that's my marketing thing, but like, they don't fit anywhere. And that's a
Well, you
very
hate
lost
to have a
hope
patient and you
place.
say, I'm sorry, I can't do anything more
Oh
for
my
you
gosh.
than give you medicine.
And it's just heartbreaking.
And,
They don't fit
I
here,
mean,
they don't
you've
fit
seen
here.
that, what happens when we give elderly people opiates. I mean, there's been so many studies over the last 10 years that chronic use of opiates for non-malignant pain is just riddled with all kinds of problems. I mean, I'm not saying don't give grandma 1 or 2 Vicodin in a day, but when you're gradually increasing that and increasing it, you see the hyperalgesia from chronic opiate use, which we see on a regular basis. I mean, it's very common. There's still a fair number of patients out there that's how they're treated. But we know it's less and less of an option. And now we have these other options that really allow us to offer something to improve not only pain, and I really emphasize this to a lot of my patients, to improve function. I can do certain treatments and relieve a fair amount of pain as long as they're sitting. But they can't get up and move around and play with their grandchildren and cook and do the things they like to do in many cases because they have a limited ability to maintain function. So it's not only addressing pain, it's improving function. And, you know, in these slides they mentioned, 1.4 million new lumbar spinal stenosis diagnoses annually. And these are only the ones that we diagnose. I mean, I don't know how many people go on without ever receiving the diagnosis. I mean, you can make a clinical diagnosis, but to truly get the diagnosis, you'd need an MRI or CT. And these show some of the findings, and this is the canal, and you see how narrow that is? I don't know if you guys look at MRIs very often, but I now look at MRIs for every patient I'm gonna consider for these. I didn't used to look at the MRI films themselves all that frequently. I'd read the reports, figure out what's going on, but now I look at MRIs. But you can see this V-shaped area is the spinal canal, and when it's that narrow, that is some pretty severe stenosis. Right here is where the nerves would exit the foramina and the lateral recesses. And here, you can tell that there's irritation of these facet joints. There's this white fluid collection, which is an indication of micromovement, which means there's some instability there, which goes hand in hand with degeneration. And how many elderly patients do you see with degenerative disc disease that have grade 1 spondylolisthesis? That's because of the degeneration, and it allows that movement and causes further narrowing. On the sagittal views, you can see the pinching here. I mean, these are pretty significant stenosis. Annually, 175,000 decompression surgeries. Now, I'm guessing that the vast majority, 99% of them, are the multi-level laminectomies with fusion. Minuteman is just making its way into the market. And, some of these other minimally invasive surgeries, they're not hugely common. So, you have the button.
Oh, I know.
It's
He just knows, it's intuitive.
So, the indications for this procedure, the Minuteman procedure, lumbar spinal stenosis, okay? We all know how to recognize it. And, on physical exam, there's nothing on physical exam that really keys into spinal stenosis. It's more of a clinical diagnosis. And they may have a positive straight leg raise. They're probably gonna have decreased range of motion. They're probably gonna hurt an extension. But how much of that is stenosis versus, arthritis, facet disease, things like that, I don't know. Degenerative disc disease, by far one of the most common things we see. How much of it's due to, how much of it is correlated with spinal stenosis? I mean, they go hand in hand. I don't know that I've ever seen or will ever see somebody with spinal stenosis that doesn't have degenerative disc disease, okay? Spondylolisthesis, again, the slippage of the vertebral segments. So basically, I don't need to read all this to you, but this is gonna segue into the actual procedure of how it's done and why there's such an advantage to doing this over some of the more traditional approaches. So, we'll go on from there. So patient selection, and please, if you guys have anything to add, if you have any questions at any point, bring it up right away. This is very informal. Okay, I'm sorry, I'm hit your time. Stenosis broken down into central, foraminal, lateral. Most patients that I see that I probably think are symptomatic have a combination, central, lateral, recess, foraminal. It's usually a combination of several of these. These type of devices treat all levels of stenosis. It's not just treating central stenosis. It's treating the lateral recess, the foramina. So if somebody has a pinched nerve from stenosis, this will help. This is kind of a basic algorithm, and I know that Dr. Batista and I, this is kind of what we look at when we see patients. Have they been through the really basic stuff? Have they tried the conservative things? And if not, okay, do we need to do some epidurals? Did they fail those? Have we looked at their facet joints, done radiofrequency or endoscopic rhizotomies? They've been through the therapy and the medication. They're not responding, for any length of time, then the Minuteman becomes a real option. If they do respond, keep it conservative. If somebody doesn't need a major procedure, don't force them into something. The insurance industry is forcing us in this direction regardless. What I used to be able to do conservatively has been restricted significantly. So people are kind of being forced down this path of more and more aggressive options earlier on. Thankfully, we have something that's not as aggressive as surgery to offer these patients when they don't get what the insurance companies think is acceptable response. Let's see. Appropriate findings, we kind of went through a lot of this. I mentioned that the facet joint effusions, that white line in there where there's fluid, that's an indication that there's some micromotion. I like this slide because intuitively, if you look at the spinal segment, it's really a three-legged stool. Okay, you got the disc that's controlling the anterior motion and some of the rotation, and then you have your facet joints, but those are the 3 points of contact for each segment. And I don't know that that's really something that we're taught in medical school. I don't know that it's intuitive, but realizing that if you have problems at any one of these areas, it can lead to pain. And with spinal stenosis, you can see right in here where this B is forming, that's a very tight canal, and that's when you start getting symptomatic. Another picture on an MRI from a sagittal view, you can see where it's narrowing down. Some other views and if you want us to stop and go over these, we can dissect them in greater detail if you'd like. So when you look at, some of the indications, if you combine the degenerative disc disease and the spinal stenosis, spondylosis, and up here, there's a huge number of our patients with back pain that are probably reasonable candidates. Doesn't mean you're going to jump straight to this, but if they fail more conservative options, this now becomes one more tool to consider.
And it's that hope thing. Sometimes they just need hope to know if this stops working, what's next? If there's something next. There's nothing, like you said, there's nothing we can do. They just like to know what's next and not. Right.
So, I don't know that there's anything on here specific that you want to discuss. Is everybody familiar with Bastrup's disease? I had to look it up a few years ago. The kissing spinal stenosis, or spinal processes, the spinous processes, or there's so much degeneration or even lordosis that the spinous processes need. I see it occasionally.
And I think that model too will fit really well.
This will. You can't see it because of the interspinous ligament here, but if somebody's like this, and that can cause a fair amount of pain. So if you open that up, that'll help. Who was it that I was talking to about Glenn, you'd mentioned the scoliosis.
Oh, yeah.
They're saying a Cobb angle of less than 25 degrees, so that's a pretty significant amount of scoliosis, but that's at the level you're working at.
Yeah.
I mean, most
Okay.
symptomatic spinal stenosis in the lumbar spine is gonna occur at L4-5. Like, you know the percentages, like 70%?
Oh, yeah,
Oh, yeah.
I think it's more than that, I think it's like 89%.
Okay, and then L3-4 is next, and those two levels probably account for the vast majority of spinal stenosis symptoms. So most of the time when you see surgery, it's at one of those two levels for spinal stenosis. That's where the majority of these would be performed. Okay.
And that Cobb angle, I get calls on all the time, it'll be like, oh, we have 30 degrees at T8, well, what are we treating? So it's really
Okay,
only
yeah,
at that.
lumbar, yeah,
Yeah.
it's usually higher in the thoracics.
Some of the studies, and I think these are interesting, because they did studies that compared the Minuteman with a direct lateral interbody fusion, DLIF, then the bilateral pedicle screws, unilateral pedicle screws, facet screws. Don't see a whole lot of facet screws anymore. That used to be common, I don't know, 20, 30
Yeah.
years ago. But we see a lot of people get pedicle screws, and that's probably the most common fusion type surgery we see, or you see in your office. If you get an operative report, that's what they're doing. And then the next slide, I think, kind of shows, and just to look at it briefly, you can see that the Minuteman shows nearly identical, if not better, stability in both extension and flexion compared to just about any type of major surgery that would typically be done by our orthopedic and neurosurgical colleagues as a traditional approach. This kind of gives you some of the breakdown, but it again shows that the Minuteman was effective, equally effective as decompression and fusion.
Very robust, I think there was our CEO and our VP hooked it up to a truck and pulled
Hooked it up a half ton and towed with just the Minuteman. They used to have this thing when I first started, like, what can we tow with the Minuteman device? And I'm like, oh my gosh, and the videos that we would get. But, and to go against the gold standard infusions. So there was nothing, no disrespect to anyone that gets biomedically, clear by itself, but Todd and them, they wanted to like, okay, we're gonna do this, we're gonna compare it to the gold standard in this space, and we're gonna go against rods and screws. So statistically, 1 Minuteman is the equivalent to 4 rods, or 2 rods, 4 screws.
Wow.
There's no statistical difference, and we're not screwing into someone's bone, we're not worrying about an angle.
And Dr. Linehan will talk about this approach, because it's a very unique approach.
Well, that's the part that I'm excited. I mean, this is the data, you guys can look
Yeah,
at this.
she's
but-
like, oh, that's good, this is now we're getting into the good stuff.
So, when you think of a traditional surgery, and being an anesthesiologist, I see these, and they're making, 4 to 6 inch incision, they're dissecting down through 3 and 4, inches of muscle and fat tissue and whatnot. And they expose the bone, and they get to the disc, and they remove the lamina, this part of the bone on either side, and then they put these screws in. And I mean, it's a bloody mess, and it's a 4 to 6 hour surgery, and it's a major involved surgery. And we had some spine surgeons at Fairfield Medical Center, and there are a significant number of complications with this type of surgery. And I don't know, if your patient population, if you saw that, but I mean, it's not a simple surgery. With these minimally invasive surgeries, and the catch acronym is MIS, minimally invasive, this is an interspinous fusion device. Essentially, I'm coming through the patient's side, and I'm staying all in the muscular layer. I'm behind where the spinal cord is. So the chances of it injuring the spinal cord are like 0, assuming you're where you're supposed to be, okay?
Are you guided?
Yeah, and we'll kind of get through some of that. Did you watch the video? Did you mention that? So essentially, once I identify, my landmarks, I'm placing a guide wire. It's the large needle, and probably the 22 gauge needle type. Is that about the size of it?
You're right.
And I mean, it's fairly long because I gotta go through a fair amount of muscle, and I'm placing it right in this space right here, okay? And then over that guide wire, we advance dilators, and it's a series of dilators that, so I'm not cutting tissue, I'm dilating it. So there's not a whole lot of tissue damage to the muscle or anything else. And you look at some of these dilators, and the final dilator with the working channel is about this big. And you're like, whoa, that's big. But I've stretched out the tissues. And you do plenty of local, and patients are half awake during this, and you're like, man, how are you tolerating that? It's impressive. But you eventually get the working cannula, and then once I've got that cannula where it needs to be, this device goes through the cannula and inserts this screw-like device that you have right here. And this is holding that space open, so you're treating the stenosis. But more importantly, it's also fusing these together, so you minimize the movement. Now, the interspinous processes that I've been using for the last couple of years, the difference is I'm going posterior. So I'm making a cut down, it's about an inch cut, but I have to dissect this interspinous ligament here. And once I cut that ligament, in order to get that dilator into that space, I've lost some of the stability of that. By using this lateral approach, that ligament remains intact. It adds stability to the whole structure of the spine in that region. So I gotta say, I've been very impressed with the logic behind it, the studies that prove it, and now in my hands the success I've seen. I've been impressed with a lot of these different procedures, but this one has some real advantages. This shows a picture of a CT, and it shows where this is actually fusing together now. And you can see where these spacers are. They're back in the spinous processes. This is the spinal canal where your spinal cord is. So I'm not near that, close enough that I'm going to cause some kind of nerve damage. So my biggest concerns with this procedure are probably infection, which I guess is possible with anything I do. But I'm making about an 1.5 inch incision in the side, and that's where I'm placing the guide wire and the dilators. There's no incision along the back.
And to add another layer to that, to the approach even, we do use a bony matrix, and that bony matrix is really what creates that fusion and that hydroxyapatite coating. It just all works together, and these images here, like you said, are 6 months, and we can see it's fused really nicely. And with that lateral approach, you don't have that recovery time. These patients aren't taking 8 weeks to recover, and I'm very excited for you to meet a gentleman, one of our patients, to speak to you tonight, because you're going to be very surprised that he's a week out from his surgery.
6 days.
Yeah,
I did his surgery last Friday.
So that last picture, there are two.
There are two
of
devices
them there.
here. Yeah.
Were those done at the same time?
That I don't know.
I don't know with this particular picture, but usually they wait 90 days. Yes.
Okay, so usually just one at a time.
Generally speaking, yeah. You try to identify which level is causing the most symptoms, and there's ways to do that with diagnostic blocks. If it's not clear, you can say, okay, what was your response when I blocked the nerves at this level versus this level? And typically it'd be fairly clear. And not that you can't do 2 levels at the same time.
Does it separate the vertebrae any when you put that in there?
It's not truly meant to distract it.
Okay.
It's meant to maintain the space there. I mean, there's probably some distraction, but you don't want to over distract and put somebody in a kyphotic posture, because what it could do to home line.
Sure.
So you want to maintain a functional alignment of the spine.
So if there's too much degeneration, that might be contraindicated to?
No, I don't think so. I mean, I think if you have severe disc degeneration, your spacer that goes in there just may not be as big as one that you'd get in somebody that had less degeneration. Because they make multiple sizes, depending on,
Yeah.
You know,
we have
okay.
multiple sizes to size each patient. So.
okay,
That makes
Yeah.
sense.
yeah. I mean, you've got to tailor it. It's
Okay.
certainly not a
One
one
size
size
fits all, yeah.
Certainly tailored to each patient.
So some of the contraindications, and one thing I guess would be to know that whether a patient had a pars defect. So you guys are familiar with the Scotty dog. So if you've broken the neck of the Scotty dog and there's a separation, you wouldn't want to do this, because obviously it's gonna cause some kind of movement there.
There's an L5.
And this shows you, that's some pretty significant scoliosis here, but I don't know that that's even at 25. I mean,
Right, and we can do scoliosis patients, we just kind of come from that outside angle, and we've done them, but there is a limit to it for sure, yeah. And like you said, just, as long as it's not on the levels that we are actually treating, if we have a severe thoracic scoliosis, let's do patients there, so.
Spinous process fracture, obviously you don't want that, since that's where I'm kind of screwing on to. That should be obvious by, X-ray or MRI. So all these things we're going to look at. So I think we're going to get
Yeah, I'll make it.
Robert here?
Yes.
And, I really encourage you guys to ask any questions, whatever, but I think it's pretty impressive that we now have some options that are really life-changing for some of these patients. And when you have somebody that's miserable all the time, or they have to sit in a chair, it's just not a really functional lifestyle. Are there any questions here?
So the contraindications would be pars defect and spinous process fractures.
Yes, and severe scoliosis.
Severe scoliosis. Okay.
And severe is determined more on your gut feeling or on specific.
No, you can measure it. If you stay, less
Just
than.
beyond this, sorry, you just can't really.
Yeah. I don't know that I would, until I've done this for a few years, start thinking about doing it on somebody that has severe scoliosis, but a lot of our patients that have degeneration have a component of scoliosis, and it just seems to go hand in hand. If they had a patient referred to more traditional surgery, what would they expect to see 1 week after the surgery, which you did the last time you were here, and then about 1 month after the surgery, which is where you are today?
Right.
So I would like you to just talk for a moment about your experience, what you were like before the surgery, what kind of symptoms you had, what kind of change you saw.
It probably over a period of 3 to 5 years, the back just degenerated to the point where I couldn't do anything. I had to retire. I couldn't work any longer. Couldn't stand for more than 15 minutes. I had to hang it up. Walking 50 feet was about the best I could do without stopping. Now 200 to 400 feet without a problem, so much better. As far as the surgery went, within hours, there was 0 pain in my spine, and there's still no pain. Like I told Dr. Linehan, the only problem I'm having is I think my muscles are trying to catch up with the fact that I can do things now in my lower back. So we're gonna get some therapy on those to get those stretched back out and see if they can come back to life. Other than that, there's virtually nothing I can't do as far as walk, bending. The change is unbelievable compared to what I had.
Guys, please ask questions.
What kind of things did you try before the procedure for the pain? What things had you tried prior to the procedure?
We were doing injections, which would last anywhere from 30 to 45 days, and I could get along okay with those, but I was still limited as to the walking and the standing.
Were you on pain medication?
The only thing I had pain medication after the surgery, and to me, ice worked better than the pain medication.
No, I meant prior to the surgery.
Oh, prior to it, handfuls of Tylenol was what I was taking.
Now, you had mentioned that before the surgery, you have a mailbox that's about 100 yards down your
Yeah,
drive, is that right?
it's 200 feet to the end of the driveway.
Okay.
And before the surgery, I had to make 4 stops, 2 on the way down, 2 on the way back. Now,
Didn't you take your medicine?
taking it.
He can walk a lot farther. He can go get the
He's
meal
a little
and
weaky,
stuff.
but he can do it.
Yes, exactly. He can go up and down the stairs now. He wasn't going to our grandkids' track meets and stuff because you have to walk to get to the events and stuff, so he missed all of that. He's just a lot more mobile now. He's still a night person and I'm a day person, so getting him up in the morning sometimes is an issue.
About showers.
But
Shower?
Yeah.
Shower, you scare the hell out of me.
yeah, you would not take showers because he was afraid it would fall. But now, thank goodness, he's taking showers again.
I've taken more showers in the last month than probably the last year.
Don't tell him that. And we live on a farm, and my parents have horses and stuff, and my dad has gotten weaker, so he hasn't been able to help as much, and so we have the big brown bales that we take out to feed the horses and stuff, and so he would get on the skid loader now and take those out so I can cut them and put them in the barrels for him, and before he couldn't even get in the skid loader. And we even had him to where we had to go out in the field and move the container around.
Move the feeder rails.
So he got out of the skid loader, then he had to get back in it without the ladder that we have in the barn, and that was no problem either. So it's been a big change, very big change for him. So we just have to keep on him.
You guys have any other questions? I think hearing you, because you're an outside observer and you can
Right.
see things, and obviously it's made a big difference in your quality of life, which, as I mentioned before, it's great if we can relieve pain, but it's really gratifying if you can improve somebody's life.
Right.
And when you're limited on how long you can stand and walk, and you can't go to the grandchildren's sporting events, or you can't lift your granddaughter or whatever, that's just a huge loss in the joy of life. So regaining that functionality is huge.
I think knowing and understanding the importance of these invasive techniques that are available. I mean, look at the other road that he could have went down. He could have went down these pedicle screws and rods, and he wouldn't be sitting here today. He would be still recovering, right? He would still be in this, probably the 6-week recovery mode where you're limited.
I have an uncle in the medical field, and when I told him I was gonna have back surgery, why am I so emotional?
This is like a football banquet.
That was worse. He told me that, don't do it.
Because of the back surgery, a lot of times, if it doesn't work, you're
He
done.
said you'll be down for months. Don't do it.
He was only down for like
hours.
Yeah.
Yeah, he didn't really follow the
No,
protocol.
that's right.
2 days after surgery, he was on a skid loader, and then he was lifting a lawnmower to do some repairs. I'm like,
Right.
what are you thinking? But
Yeah.
it's a solid fusion, and
Right.
now
He
it's
felt
time
so
for
much
therapy.
better.
If you don't mind, I'd like him to see the surgical incision side. If you could lift your.
Oh, yeah.
You love more to see that, don't you? Others are much loved. There's just this little.
So
Yeah.
it's through an incision like this, and I'm going through the side, so all the structures midline to support the spine have been avoided. It's just, it truly is an amazing advance in the options that we have to treat these problems that are very common, and just gradually steal the quality of life from people, and you don't even know it. You
Right.
become.
Now, I won't fool you, the surgery, the incision and the Mariana's Trench they dug to get to the spine, that hurt for a good week and a half. But now, like I said, the only pain I have is the muscles trying to catch up.
Are there any other questions?
Have you started like formal physical therapy after you put the device in? Have you done that yet? Like,
I'm gonna try to start therapy probably next week sometime.
Yes. Yeah. Need something like that.
Did you only have one, one spot in your back that you needed it?
His was L3-4.
L3 and 4.
Now, he has some problems at L4-5, but they don't seem to be nearly as symptomatic, but who knows, over the next few years, that could progress to a point where we have to consider, repeating it at the lower level.
And the beautiful thing about the minimally invasive, the footprint is small, so that there's other things that need to be done later on, even by other physicians, or, at the degenerative disc cascade that we talked about, we've just made a small footprint, so.
Yeah, there's no sensation of the appliance being there, none whatsoever, so.
We wouldn't have to take anything out. You can just put the next one in right next to it and you're good to go.
Yeah.
So if you were to need the lower level at a later point, how quickly would you sign up for that procedure?
That depends on what the boss shows on their x-rays.
As soon as he let you, or would you be?
I wouldn't worry about it personally until I start having those pains
If you
again.
were in pain?
And then I'm gonna do the same route, try the injections for a while, and then go to the appliance if I have to.
Okay.
Always start with the conservative stuff, just like how I treat my mom. I think that's the key.
So one of the things we're tracking is that adjacent level. So because of, the anatomy intact, one of the things Spinal Simplicity is tracking, do we have the adjacent level after infusion going? When we didn't dissect the muscles, when we didn't dissect what nature intended to stabilize the spine in order to stabilize the spine. So the stats will come out. Obviously, degenerative disc is mother nature all the time anyway, but by doing an open, sometimes you're aiding to that because you're taking away what nature stabilizes the spine. So we're gonna see about that adjacent level.
And I'm sorry to be so emotional.
Oh, you're too young to not be able to do what we do. I mean, my parents are in their 80s and still have the farm, so
Yeah.
he's only 60-something, so
Well,
not ready to dock a ship yet.
Well, for us, it's so important for you to share your story, because they're gonna go home and they're gonna see these patients and they're gonna be able to identify that so many more people are gonna be helped because of your story. So I hope you know how important that is, how much we appreciate that.
I really think it's done wonders. I was really nervous, because with back surgery, you just don't know. One wrong move and you're done. And he was fine.
Just on one final thing, and I don't mean to get too technical, but because I had these same questions. I'm like, the idea of just putting a spacer in there and still having some movement, is that gonna provide better response by allowing some movement as opposed to fusing? And they did plenty of studies on the biomechanics of the spine. And when you still have movement there and it's an unstable segment, the levels above and below actually take more strain because of that movement, because you get a wobble effect. So if you can stabilize that segment that is degenerated, stenotic or whatever, you reduce that wobble effect, which is gonna reduce the progression of the disease above and below. Makes perfect sense now that I think about it in those terms. But what Katie said is absolutely true. With this procedure, I'm not cutting this interspinous ligament. There's a natural stability to the spine that we're preserving. And I really like that approach, and that's why this is gonna supplant what I was using for the last couple of years in a different approach.
Because just talking to people as to what I was gonna have done, you're gonna be down for 6 weeks, you're gonna be down for 6 months. After they cut the muscles, and I said, this doesn't cut the muscles. Oh no, they gotta cut those muscles to get in there. 2 days later, I was up on my feet and going.
Where else do we find the Minuteman in this country? What other specialties have started working on installation? What other locations?
Well, this is approved all the way from the thoracic to the lumbar spine.
Would you see PM&R ever doing it? Would you see?
There are PM&R dogs that are very involved in, if you could ask Ashley, you know who's training for it.
Yeah, so we've been very selective because we know that this is kind of revolutionary in the space. Like Katie mentioned earlier, they talked about this as 13-year overnight success. Originally, it was kind of tailored to orthopedic spine and neurosurgeons, but we realized that this minimally invasive is now your space. And so branching out, it's interventional pain, yeah, and that's about as far as we've got, outside of orthospine.
And spine and neuro have also.
Yes, oh, yes, and they do currently, yes, it's just grown off of that, and the way they've tailored the device, with the minimally invasive approach, right, because this is really their wheelhouse.
That's why a lot of these minimally invasive techniques have come into pain management realms. I mean, they were generally marketed toward the orthopedic and neurosurgical spine guys. I think what Ashley said is very important, and I bring it up every time I hear about a new procedure or a new twist on an old procedure, is who are you courting to learn these things? Because to me, it's very critical that they just don't take this to anybody that wants to learn a new procedure and isn't really gonna put the thought and the energy and the time into proper patient selection. Because in my time in pain management, I've seen several very decent procedures go to the wayside because it was over-marketed and it ended up in the hands of people that weren't doing it for the correct reasons. And the next thing you know, the success rate hits the toilet and the insurance companies say, we're not covering this anymore, and it's gone from the market. And you think about IDET, and you remember that. You know, there are a lot of procedures out there that have gone to the graveyard because they were marketed too aggressively to people that really maybe weren't the appropriate candidates to be doing it in the first place. So hopefully, you know, and from what I could tell, they were very selective about who was at some of these conferences. So it's not just anybody that's just, you know, been doing nothing more than epidural steroid injections. These are guys that have been doing some more of the advanced techniques for some time, or at least been trained in them.
Absolutely. I want to dive deeper into that, but I don't want your food to get cold. Because I know you still have to
serving, yes.
But thank you guys.
Thank you. Do you guys have any more questions for them at all?